Good morning, everyone. My name is Nigel Tomlinson. I'm the Principal Scientific Advisor of the Department of Health, and I work in that part of the department which is responsible for the built environment and the provision of facilities. I'm delighted to have been invited by the British Institute of Radiology to speak this morning. It's the first time I've given a presentation at the Institute, of which I am a member, for some 8 years. Last time I was here, I spoke on K-edge effects on iodine in angiography. Today I'm going to speak about something which is essentially political and is essentially about change and the way in which it affects radiology, radiotherapy, and the buildings and installations that are used to provide those services. From the outset, I think it's important to say to you that this is a time of radical change. We have a new government from May last year which is moving toward outcomes-focused guidance, even in areas which appear superficially to be rather unrelated to outcome for a patient, such as the design of an X-ray room. It's not immediately obvious how X-ray room design and patient outcome relate, but the Department of Health does believe there are relationships there, does seek evidence, does work toward preserving that outcome-based thesis, that outcome-based attitude right across its output. This means we need new ways forward based on care functions, and it means that much liked concepts, including the health building notes. I was one of the co-authors of HBN6 in radiology, and the HTMs, the health technical memoranda, are going to change. In fact, they're going to disappear and be replaced by new concepts which are related to the modern policies of improved outcomes in healthcare. Having said that, I should emphasise that I'm the principal advisor for England, and that English policy and that for the other three home nations, Wales, Scotland and Northern Ireland, is likely to diverge because of health devolution, and you are likely to see many policy initiatives, directions, strategies that differ between those countries. The healthcare landscape in England is being reshaped. It's being reshaped by this document, Equality and Excellence, Liberating the NHS. If you work at the Department of Health, you have the slightly uncomfortable thought that what this means is liberating you people out there in Cyberland from me in Whitehall. It means transferring the thought process, the decision-making and much of the responsibility to people at local level who are actually doing the work and who genuinely have a very high level of understanding, a very high level of insight into what is necessary and what is likely to be efficient. It's important to understand that that transfer of influence, that transfer of power, is core to the new guidance programme, which seeks to avoid dictating to you and seeks instead to give you choice. There is a progressive introduction of health group commissioning. This was to have been general practitioner commissioning, but people will recall debates in Parliament and debates with the professional and learned bodies in which it was thought that general practitioners were perhaps not a full base of expertise for the commissioning purchase process. And as a result, government moved in the current health bill toward a broader base of expertise being involved in that commissioning. We're in the process of the formation of the National Commissioning Board, which will essentially set the rules for the purchase of care from providers by commissioners at local level. We have a much more developed role for NICE. NICE will be part of the glue that stitches this more diverse, more competitive healthcare scenario, healthcare structure together. NICE will be producing care standards, which define methods of care, the quality of care to be achieved, though many will seek to exceed those quality indications, and to incorporate those standards into care pathways so that patients are well cared for from initial presentation through to an acute episode, if there is one, with acute solutions like surgery or interventional radiology, through to recovery and, if necessary, rehabilitation and reintegration into society. It's for that reason, partly, that health and social care are being brought together in order to close the gaps through which people fall. It is not helpful or appropriate to spend a large amount of money on a complex treatment, perhaps on an elderly lady who lives alone, and then send her home to a cold house with no one in it, where the electricity bill hasn't been paid and where she immediately goes down with pneumonia. You've spent a lot of public money, you've done a lot of work, you haven't achieved anything. So the new care pathways, some are not so new, seek to bring the care profile together. Development of the Care Quality Commission, originally to have been an inspectorate, but with changes that have now occurred in the bill, a regulator, Ian has already said something about. I will return to that subject in a moment. Many of you will be aware that some of the arm's length bodies have been abolished. Others have been changed from arm's length to being brought into the Department of Health and other parts of government, as Ian indicated. Still further groups have been reconstituted. The reason for doing this, apart from cost saving where that is available, has been to shift from a target-focused culture toward a culture which is focused on the outcome for patients. 3 years after an acute episode, people will remember the care they received. They may have affection for nurses, for other people who took part in the care process, perhaps for a radiographer who was particularly thoughtful during an examination. But the main thing they will know, they will think about, is how well they are. If the episode has been successful and the outcome has been valuable to that patient, that is an outcome success. And the new government, the coalition, wants to move from targets on issues like waiting time toward targets which are concerned with what the outcome for the patient might be. This has implications right through the policy and guidance structure of the Department of Health, perhaps surprisingly, reaching into areas as apparently remote and technical as the design and provision of facilities in radiology and radiotherapy. I will try to explain the integration of this thinking as I go on. These are the new structures in health, or they were the new structures in health when government first published them. The most senior institution in our country through the democratic process is Parliament, and the Department of Health is responsible to Parliament through the ministerial team, led by Andrew Langsley, our Secretary of State. The new commissioning board I mentioned a few minutes ago receives policy, when it's fully operational, from the Department of Health, which guides on things like expenditure, quality of care, care emphasis, things like ensuring that mental health is not a poor relation of acute care. Alongside the commissioning board, we have Monitor, or the economic regulator, which works as it says it works. It's concerned with the NHS and other care providers being solvent, being around to provide care because their finances are in good order and because they are spending money wisely and appropriately. The Care Quality Commission, now a regulator, is concerned with something called EQR, Essential Quality Requirements, and the Department of Health will work with the other institutions shown in this diagram to establish essential quality, to render this a requirement within policy and guidance, and to disseminate that to the other institutions. This means that the Department of Health, instead of directing providers of care, advisors, commissioners of care, economic regulators, and CQC as the quality regulator. It is a major change in the Department of Health's role. As the bill has progressed through public consultation and through Parliament, however, some of the direct connection to the provider has been restored. So this diagram is a little outdated for that reason, and I'm sure government will publish a revised version more or less when the Act is complete and receives royal assent. On the bottom line, though many people will put them on the top line since they're the people who deliver care and are therefore perhaps most important, we have local authorities getting involved in health now as well as social care, another very important change. Local Health Watch, which is a patients group throughout the nation designed to empower the patient. So if you're thinking about the design of an X-ray room, you may want to consult with local patient groups on that room and its design and on the facilities that support its use, waiting areas, lavatories, catering facilities, the things which as a patient make the difference between a long, boring wait and something which is quite acceptable because you are aware that the hospital is busy, but you are being well looked after during that waiting period. Health Watch will have some teeth in that it will be able to report to local authorities. One hopes there will be positive reports as well as negative. And not shown in this diagram, but there will also be a link through to the Care Quality Commission, who will be able to receive, I hope, praise as well as criticism when providers do a good or perhaps less good job in the care of a patient, at least as the patient perceives it. Pivotal to the debate in Parliament and much of the public debate was GP commissioning, now modified to health commissioning with a broader range of professionals being brought in, something which many people expect to strengthen this purchase process. But if you're thinking about radiology provision and facilities, those people who commission are key. Are they going to commission the service that you want to provide by the use of that facility? Does the facility you are designing meet the needs of NICE standards and care pathways? Are you providing a facility which is relevant to future care? In short, you're in a competitive environment and you need competitive facilities that support you in being successful. In the right-hand corner, of course, is most of you, providers. I used to tell a very bad joke, and I'll tell it now. If you get run over in the street, no longer demand that the ambulance service take you to a hospital, but instead that they take you to a quality-approved provider of care. I think you might find this difficult at times of stress. And then at the bottom, but of course really this diagram is inverted, and these people should be at the top, all of us, when we are patients and members of the public. An experience I've certainly had in recent years when I've been cared for very effectively. I want to talk a bit more about commissioning because I think this will affect you as you plan radiology facilities and make choices of equipment in the future. This is not my slide. This is directly from the Prime Minister's office and relates to high-level thinking on what commissioning is. The key issue here is safety, effectiveness, and experience. Safety, Ian has already said something about. IRMA, the medical exposure regulations, is seen as a key part of safety in terms of this output, quality-orientated future healthcare system. So keeping patient doses down, being able to compare them to national reference values, being competitive in those terms is part of delivering good care. It's also part of designing an effective X-ray room and choosing the most appropriate X-ray equipment. So there is a direct connection there. However, when this was written, healthcare-associated infection, which is an area I work in, was particularly emphasised. 7% of patients, inpatients, in hospitals in England are unfortunately infected. Gram-positive bacteria are the most common, but there's a very broad spectrum of infection taking place. And one of government and the Department of Health key criteria for the design of hospitals, and this includes radiology facilities and those used for radiotherapy, is cleanliness and the suppression of infection. So this applies to you. Effectiveness. This is all about outcomes again. What are your mortality rates? If you're performing interventional cardiology, what sort of success rates are you having for stenting? How long are those stents lasting? What sort of replacement rates are being seen? How many patients are penetrating through to surgery? These have always been key issues, but they're now key to the focus of healthcare policy. So when you are thinking about facilities to upgrade a hospital, how much angiography facility is needed to provide a proper response to your place in the care pathway? This has always been important, but because of commissioning, where people are buying care from you, you now have to get these decisions right in business terms. And because those decisions must be yours, guidance is being reshaped to give you the freedom to make those decisions in an unfettered but safe and risk-controlled fashion. The floor provided by essential quality requirements will always be there and will be subject, as Ian Chell has said, to enforcement. But above that level, and radiology does not normally operate at a basic level, it normally operates with an aspiration for excellence. Above that level, the decisions are yours, not ours, but we do provide you with a framework within which to work, which is backed by policy and is therefore defensible in the terms that Ian was kind enough to explain. Lastly, there's experience. Everybody has had a good and a bad experience in hospital care. The new government wants to put particular emphasis on people not only getting well, but on people having as comfortable an experience of the healthcare system as possible. So this again relates back to facility design and provision. Have you actually got enough capacity to deal with patients in the care pathways which have been commissioned from you in a timely fashion, in a way that allows them to feel like people, in a way that allows them to feel treated in a very human, very responsive way, and not as patients passing through a machine? That attention to personal detail, to real quality care, is something which the Health Act emphasises, and which I would emphasise to you as a key parameter when you're thinking about design of rooms, selection of equipment, and the way that room works within the overall hospital environment. So there is a strong connection between being in a competitive position with your local commissioner and the facilities you use and the way you use them. And it's for that reason that the guidance must reform to give you choice so that you can be competitive in that environment. So, who's being advised and involved? I've already said one or two words about this. The established guidance, the HBNs and HTNs, were orientated toward healthcare providers. And really no one else. The commissioning system didn't exist when those documents were written. Healthcare was about health authorities who were essentially providing local government and governance and audit systems, and providers who gave care. Today that's different because the commissioners are there, the Care Quality Commission is there, and there will be considerable economic pressure. Perhaps there always has been, perhaps the last few years have not been as easy in economic terms as we might all like to think, but there will certainly be additional pressure because of limitations on government borrowing. The future guidance will retain the information the Department of Health knows you all value. So if we're talking about HBN 6 being redrafted, advice on the specific design of rooms will still be there. It will still relate to the 1999 ionising radiation regulations and the rest of the regulatory package, most of which is derived from the learned processes of the International Commission for Radiation Protection and institutions like this one and the Royal College of Radiologists just next door. That will still be there, but there will be a new focus on commissioners and on the commissioning process and on encouraging you toward excellence, toward keeping your costs down, toward being a very competitive institution that succeeds. I made a visit to Guy St Thomas's on Tuesday of this week in preparation for giving this talk. I felt I needed to be in the atmosphere of a radiology department and cardiology department to get me thinking, to get me orientated toward what the day-to-day problems look like. And they are already thinking in competitive ways. Not only is our room adequate, but is our room actually such that it promotes real excellence? That kind of thinking will lead to success. People who adopt that attitude will be leaders, will be in the forefront. Quality regulators are being extensively consulted in the drafting of policy and guidance in this new way of thinking, but they will also be bound by it. The idea is to ensure that what you hear from the Department of Health as policy, what you see as department guidance, what you see as audit by local self-audit, means the audit you yourselves do, and audits which are done for you by the Care Quality Commission, that they are all compatible, that they add up, that there are not conflicts, at least not unnecessary conflicts. LSA programs will be an increasing part of what government asks you to do. LSA stands for Local Self-Audit. And again, it's about institutions being responsible for themselves. So in terms of an X-ray room and the X-ray system present within it, at commissioning, we look at environmental doses. We repeat that at intervals. We are cautious about the maintenance of things like protective doors and screens. We are cautious and we conduct audit on things like the provision of protective clothing, glasses, and so forth. That's where local self-audit is important. And I think radiology and radiotherapy have a substantial advantage over other parts of the healthcare system in that they are very used to local self-audit. It is already a part of the culture in the way that you work. But it will be key to your being on top in the commissioner-provider relationship. So if you have these things well developed, good. If you don't have these things well developed, it's the time to give them emphasis, and the guidance will help you to do that. The Department of Health has constructed mathematical systems. I led this project, which are designed to allow you to evaluate your audit in a less box-ticking, more cohesive, more comprehensive way, so that people who are simply good at focusing on key points don't in fact do well. People who are focused on core, in-depth quality excel. And we'll be offering that mathematical system to institutions like this one over the coming months for them to evaluate, and if they wish to use. There certainly won't be any element of compulsion. So who is going to produce guidance in the future? In England, the department will remain responsible for policy, and will integrate this content into a new framework structure. Framework structure are the words I should emphasise. The framework, you'll note this is not rigid and not dictatorial. The framework will provide for choice and functions, and it will do this on a risk control basis. So the idea of an equivalent measure, where there are several measures offered in the guidance which may each be effective against a particular risk, is being introduced, and you will choose the strategy to take. You may want to invest in a better X-ray room, or alternatively you may decide to combat a risk through improved local policies and procedures. The choice will lie with you, though of course you must comply with the legal regulatory framework. But the guidance will afford you choices within that framework. I know this is difficult to get your head around, because in the past Whitehall has always said, here's the legal framework and here are the choices for compliance with that legal framework. I'm very sorry, because I know many people would like us to continue doing that. I get many letters saying, Nigel, why are you bothering us with all this? Why don't you just tell us what to do? Terribly sorry, that is no longer a core function of the Department of Health. Core function of the Department of Health is to provide you with sound policies, sound essential requirements, an indication of what best practice is, choices, and a framework for action. That is really quite different to an HBN that says an angiography room looks like this. I hope you will enjoy the process of change. It certainly is designed to maximize respect for the expertise of professionals working in hospitals and working in local commissioning groups, and minimize the interference from those of us who provide policy from Whitehall, or actually in my case Waterloo. Directive guidance will still be necessary. We've obviously got to meet essential standards. We obviously have to behave cohesively as a country so that people recognise that it is a healthcare service. So directive guidance will be there, but it will only be high level. The detailed guidance will not take that form. The use of international standards, such as those from CEN at European level, ISO in North America, BSI here at home, and I included the ICRP, who are not strictly a standards organisation, as an example of a group with direct relevance to radiology. Their output, their standards will still be respected. We are a signatory nation to the EN scheme, the CEN scheme, and therefore we take particular note of CEN standards. But that does not mean that guidance will always slavishly follow the standards published in this way. If our country requires flexibility, then that flexibility will be worked toward. So who's going to do all this work? And the answer, I'm sorry to tell you, is to some extent not me. And not because I'm retiring at the end of the year, but because my function and the function of my successors is changing. There will be working groups, and we've already started piloting this in the very important area of surgical instrument management and decontamination. We're also starting a pilot project which is concerned with the built environment for oncology services, and that extends to radiotherapy services. So some of your work is right in the forefront of this change process. Working groups on each key clinical area, working with learned bodies and professional bodies. So we will be inviting, asking, begging institutions like BIR to become much more involved, not in critiquing the guidance that we all use, but in creating that guidance. There will be a governance system so as to maintain standards and cohesion. Other groups outside the Department of Health framework will, provided they perform well and meet governance criteria, be encouraged. So you may find the Department of Health hands over a complete chunk of guidance to somebody else and only provides policy in that area. How is the guidance to be validated? This is validation by the Department of Health. The steering groups will evaluate and provide constructive critique. Where practical, we want to use piloting. In the area I'm currently responsible for, which is surgery, I've been piloting changes in guidance. So instead of introducing them on a national basis and, in effect, trialling them when they are in use, we're doing it with pilot centres. These include one Scottish centre, which is clearly outside my jurisdiction, in Edinburgh. Newcastle has been incredibly productive in terms of contributing ideas and has done so much to reinforce the Department of Health's view that getting guidance into local systems is a strong policy and will work. Great Ormond Street has worked with University College to produce some excellent work. Southampton University hospitals are also major contributors. So we see practical piloting to ensure that guidance actually works, that the choices can be made, that the choices are valid as a key way of moving forward. I should emphasise two other key aspects. One, if it's not evidence-based, we don't want it. That evidence may well be expert opinion, but where something of higher grade is available, we will tend to emphasise that high-grade evidence, just as institutions like PIR always do. Lastly, like the Health and Safety Executive, the Department of Health will be focusing on risk prevention and control. And so the guidance is shot through with that philosophy, and you will be asked to carry out risk analysis yourselves and use that risk analysis to make choices about risk control. This is very different to the HBN, which said, right, there is a risk of external radiation penetrating into corridors, and the way you deal with that is, and here's an example design, you'll be required to give a lot more thought to how to optimize this for your institution. Policy and guidance in radiology, then, being specific. On the left, diagnostic radiology, on the right, cancer care and therefore radiotherapy. And these are our current thoughts, and I should emphasize these thoughts are not yet mature. This is a large change process. It isn't complete, so the things I say must be taken with caution. They are liable to change. Radiology, we think, requires guidance modernisation. HBN 6 is now a really quite old contribution, and we think there's real need for modernisation. We need to take account of changes in regulation, but more importantly, changes in technology. The medical engineering companies have driven systems forward. New interventional techniques have been developed in our hospitals and those overseas, and HBN 6 is not keeping pace with this. I should emphasise that in order to cope with rapid changes in medical technology, and in order to cope with the idea that providers are making choices with their commissioners, guidance will be updated every 6 months, not every 10 years. So it will be living guidance, and it will be up to you, rather more than us, to keep it up to date, to keep the department in the loop when changes occur, to ensure that there is something dynamic, something fairly exciting going on, and that the guidance is not stale. In cancer care, a programme to modernise the guidance has already started. A panel of experts has been appointed, including members of this institution, and we are moving to reflect modern care standards and pathways. Cancer care was perhaps the area in which the concept of care pathways developed most strongly, most vigorously, and dare I say it, first. And therefore we think that developing this new generation of guidance in cancer care will be instructive and beneficial for the remainder of the clinical community, because lessons can be learnt from what is already known in cancer care. There will be a focus, of course, on the improved outcomes that I've described and the way in which they relate to the built environment in which care is delivered. This focus on improved outcomes and better patient experience cannot be overemphasized. It will relate to things like appropriateness of the location of your facilities, the level of provision of diagnostic imaging facilities. Do you simply have enough X-ray rooms to cope with the work demanded by the care pathways you're servicing? Is it appropriate service available when it's needed? So are delays occurring in the care pathway because of a facility limitation in your institution. Where that is the case, you should be working with your commissioner to offset the problem in the short term and then perhaps to undertake development to correct the problem in the medium term. Is the equipment accessible in routine or, if applicable, urgent situations, such that, again, the efficiency of the care pathway and the safety of the patient can be properly preserved? If the X-ray room is inaccessible in a remote location of the hospital, nowhere near the outpatient clinic, nowhere near A&E, nowhere near the people who need to use it, frankly, you are not doing a good job, and the guidance will catch you out. What are the pre-existing weaknesses in design where you've got existing facilities, which may be limiting your efficiency and the quality of your outcomes? We want you to look at this very hard. We want you to look at it locally. We want you to decide where these weaknesses are. Can you give a better patient experience in imaging facilities and radiotherapy, which works well from the patient's standpoint, so that the patient says, I enjoyed being in that building, I enjoyed being cared for within those facilities, if enjoyment is appropriate in the healthcare, if you're in pain or discomfort? Can you make that patient experience work? Can you ensure that the patient's relatives or other carers who may accompany them are properly catered for and made to feel welcome, are able to support the patient whilst that patient is in your care? Do your facilities permit that, or are your waiting rooms much too small so that only the patient can be present and everybody else has to be asked to wait somewhere else, removing that link of care from a family or a friend or someone else who has given up their time to take part in caring for that patient? Better risk control within an efficient overall envelope. In other words, if we're reducing risk by an innovational measure, can that same risk reduction measure give us an improvement in the quality of care? So if a facility enables a safer environment for interventional radiology, can you promote interventional radiology, generate more of it at higher quality through having that better facility? Remember when I worked at Guy's, we built a new interventional radiology laboratory. We spent a lot of money on it. It was large. Every detail of its design was pored over by the radiology team, by their surgeons, by the hospital's community. The net result was superficially lavish, but in reality very effective in promoting the contribution of interventional radiology. It upped the value of interventional radiology in the hospital. Facilities can do that if you are imaginative in the way you create them. To give choice over local policy rather than use an approach of dictate from us. I say that at the end of this specific section on radiology because I want to emphasize it. It's about respect. It's about the respect that we and ministers have for people who commission and provide care. And it's about not diminishing your importance in the processes that you carry out. I was asked to speak on Space for Health, so I'll do this very quickly. The first thing to warn you of is that there is a cross-government review of communication and education devices going on. So that although Space for Health is now in place and it works, and I'd be delighted if all of you applied for a password to use it. It's free if you're in the NHS and inexpensive if you're not in the NHS. But please be aware as you use it, as you contribute to it, because it has portals which are designed to get you to feed back your views on it, how we can improve it, and so forth. Bear in mind there's a cross-government review going on. You will be asked to contribute to that cross-government review, and Space for Health may be improved or even replaced as a result. What happened when we asked people, what do you want in an information delivery system for guidance in radiology and other areas? And they said some pretty direct and simple things, which tends to be the case. If you're a shrinking violet, then working at the Department of Health is probably not the job for you. We want it now. You always want it now, I know that. We want it to be easily accessible, any laptop with a wireless connection. We want it to be specific to us. We don't want some general guidance that's sort of vaguely about radiology or some related area. We want it to be about radiology, about radiotherapy, about the areas in which we work in very specific terms. And as a result, there'll be a lot more guidance in terms of the way it's packaged, because each package will be tailored. We don't want to break the link across the UK in terms of guidance. And a collaborative agreement has been signed after a lot of, it must be said, very willing and active negotiation between the four home nations, England, Wales, Scotland and Northern Ireland. The guidance will not be the same in these four home nations because the healthcare policies are not the same in those nations. But we are trying to design it such that changing guidance to suit the nation you're in is easy. If you log in from Wales, you will get the Welsh version. You'll be able to select the English version and so forth if you wish, but the default position will be Welsh. Ditto the other home nations, of course. What is new, each healthcare administration will endorse material appropriate. It says here to its location. I would have said to its political structure. Because it's not the fact that you're in the Swanley, it's the fact that it's the Welsh government who are helping you, not the English government, and that's really the key. There'll be a significant amount of content that's the same right across the UK. The ionising radiation regulations, of course, apply across the whole of the UK, and therefore those parts must be constant. Users working on projects across the UK, so people like Siemens who are represented today, will be able to look at the guidance specific to the country in which you're providing healthcare imaging or radiotherapy system. We hope this will work well. I'm sure there'll be teething problems. I'm sure that constructive criticism will help us to get it right. There is a move toward using core information wherever we can. Many rooms in hospitals will have core aspects in their design, for example, the prevention of infection. And it makes sense if this is dealt with in a more or less universal way. The added value content is all about your making choices and driving up standards. This next part is very ambitious and sophisticated. It's about what replaces health building notes, working directly with clinical services and evolving with that clinical service, and is the reason for the 6-month revision that I've already talked about. The space veil system, which we developed at considerable cost, is designed to be able to chase and even lead that change process. There is a scheduling tool included in space veils, which is designed to help you to plan new or revised facilities from the realization that the care pathway is not being well served through to the moment, and I've had this experience when you push the door open on the final day of commissioning and you invite the first patient to be cared for in that particular room. So powerful web-based scheduling tools, private to you, but very flexible, which combine the experience of the national community in terms of how to project manage, how to make things succeed as programs, are being developed within Space for Health. Over the next few months, you'll see this growing in capability and what my boss likes to call dynamism. I think he's reflecting energy and optimism and change. Last slide. To summarise, the guidance will have a part structure so that it can be revised easily and it can allow for the differing national policies of the 4 home nations. That is where they do differ. There will be commonality. There is a move to a risk control and choice-based approach, as I've been very keen to emphasise to you. I know this is unfamiliar territory. I know that some of the choices will be challenging and difficult. I know that your professional and learned bodies will support you in understanding those choices, and the Department of Health will want to work with those professional and learned bodies closely in developing these new relationships focused on outcomes. There will be coherent advice to commissioners, quality inspectors, and most importantly, care providers, so that the system works as a system and the gears mesh and don't clash any more than they have to. Nothing is perfect, but we want to minimize the misunderstandings, the conflicting guidance, the multiple guidance in the same area, which doesn't allow choice, but tries to introduce rigidity. We're trying to get fluidity. We're trying to help you to be adaptable. Focused on improved outcomes, including the patient experience and the safety of the patient. And the health bill actually doesn't deal in great detail with the safety of staff, but of course the guidance will always put that safety aspect in a preeminent position. Use of practical information wherever it can be obtained, from pilots, from successful schemes. And one thing I haven't mentioned, it's always a bad thing to mention something for the first time in the summary, but I'll break that rule. We are able to annex reports of good experience, reports of things that work, to the guidance. This was something we never did before, but we are now going to be able to do that. So if you are any town hospital and you produce a very efficient system based on very good facilities for the provision of perhaps an angiographic service or an aspect of MRI, you will, if you wish, be able to share that with the rest of the community. I'm sure you do it through BIR already, but you'll also be able to do it through the guidance in a way that the Department of Health has observed and in a sense approved of. Lastly, ongoing approach to developing space for health, or what succeeds space for health. One aspect of that, which again I haven't mentioned, is that the evidence we use in creating the guidance, which was previously not something we listed or made available to you, it may have come from your own journals, but you were unable to see where that evidence had come from, will in future be listed and will be graded in two ways. One, what we think of the quality of that evidence from expert opinion through to full-blown meta-study, and in radiology both are very prominent, and in terms of the influence it had on the guidance. So this was a very good study, but its relevance to the guidance was somewhat tangential. So although it gets a high score as a study, its contribution to the guidance is small. Any of you who have been to talks of mine before or webcasts of mine before will know I always finish with a photograph of a boat, and this normally causes joy among my audience because they know at long last I'm going to close the talk, or as they might say, shut up. So thank you very much for your attention. I've run rather over time, but I will, at the chairman's tolerance, answer questions if you so wish. Thank you.